MetaStand Understanding Medicine.
Professor Azizur Rahman here. Let me start today's lecture with this statement that there is only a small chance that any of us will be able to do something really extraordinary in lifetime. Because, extraordinary things are done only rarely, and doing something rare is actually based on luck and the chance. However, there is a good chance that all of us may be able to do ordinary things extraordinarily well. I believe this should be the aim of our day-to-day life. And why this statement? Because I think approach to anemia is based on this basic principle that if you focus on small details, I think you may be able to make a correct diagnosis and may be able to offer a proper treatment without spending too much money on resources, and something simple which can lead to serious complication may be easily corrected. So let's start and let's see how we do that. The topic of today's lecture is approach to anemia and introduction to complete blood counts. This is the simple test abbreviated as CBC, very famous and common test, usually the first test whenever we start investigating anemia. So I think my focus would be on CBC. First of all, we will have some introductory slides and then we will give you some introduction to CBC, but detailed interpretation of CBC will be covered in the next lecture, which will just follow this one. Now, introduction to anemia. What is anemia? It may not be actually easy to define anemia because we usually refer to hemoglobin concentration or hematocrit or packed cell volume. If that is below the defined limit, we call it anemia. But that is also dependent on our water contents. So I think the true measure of anemia would be actually measuring the total red cell mass in the body, but that is not easily possible. So we just refer to HB level, hematocrit level or MCV level, and if that is below the defined range for the given gender, we classify it as anemia. It's a very, very common problem, especially in our part of the world. Very, very common problem, often overlooked because it does not cause very dramatic symptoms, especially when it is mild. Very, very subtle symptom or many times no symptoms, and it may be just an incidental finding. So if somebody is being prepared for an operation or routine antenatal examination, blood test may discover anemia. Various causes, but iron deficiency is the commonest in our society, at least. I am not sure about Western society, but in our society, the commonest cause of anemia is iron deficiency because iron is very important ingredient, very important nutrient for the hematopoiesis. So deficiency of iron can cause anemia. Although iron deficiency may be itself due to several causes, we will discuss them when we go through the history. Simple iron replacement or simple prescription of Hemetanics is not the solution. You must give it a good thought. First, try to find out the cause of anemia and then I think prescribe whatever you want to prescribe. Just looking at the patient and seeing some pallor and prescribing iron may not be the right approach because there is a chance that you might actually miss the underlying disease, which might need separate treatment. So I think you just need to at least take detailed history, do physical examination, do some basic labs to determine what is the cause of anemia, and most likely it would be iron deficiency, but other causes are also likely possible. The best time to investigate any condition, I believe, but we are discussing anemia, so the best time to investigate would be before you start medication. Because once you start medication, once patient is given blood transfusion, and that is fairly common approach in our country, though this is not very much recommended these days. So somebody after transfusion, or somebody who has already started receiving medication, the picture of blood may change and you might not be able to come up with the correct diagnosis. So best time is before you start giving medication, and actually there is usually no emergency. You can take 1 or 2 days to investigate the cause of anemia and then start treating. Classification of anemia can be based on etiology, or it could be morphological classification. And here I will give you etiological classification, but in the end of this lecture, and then we will start the next lecture with morphological classification, because morphological classification is actually based on CBC. That will be covered in greater detail in the next lecture, but here we will just talk about the etiological classification. Etiological classification means that if you can determine the cause of anemia, and I think we can give a specific class to the patient, the category to the patient. Theoretically, anemia may result from reduced production. You know, blood is produced in our bone marrow. So for whatever reason, if bone marrow is not producing enough blood, that may result in anemia. And this could be due to deficiencies. For example, iron deficiency, folic acid deficiency, protein deficiency, other nutrient deficiency. So they can cause, and folic acid, all these things are required for hematopoiesis. So if one or more of these nutrients are deficient, it may result in anemia. Or when bone marrow is not working, mostly it is because of some endogenous disease of bone marrow failure, there's a condition called aplastic anemia, or bone marrow is infiltrated with some malignant tissue, or in some chronic inflammatory condition, bone marrow is suppressed. So either of the two, either there is some deficiency of some nutrient, or bone marrow itself is not working. Both of these conditions could result in anemia. Then there may be increased loss. You know, our RBCs have average life of 120 days, but sometimes you may lose blood, and or sometimes cells may be destroyed, and thus average life of RBC may be reduced. So there could be external losses, like one is losing blood from hemorrhoids or acid peptic disease. But commonest cause of chronic blood loss, especially in I think not especially, only in women, is menorrhagia. Okay, so I think, in my opinion, this is very common. Whenever you confront a case of anemia in a woman, you must rule out the possibility of menorrhagia. But there may be sometimes internal losses, the occult losses. Somebody having acid peptic disease, or somebody having some colon cancer may be losing blood inside, and that may also cause anemia. And internal losses also include hemolysis. Cells may be destroyed. There's a whole long list of causes of hemolysis. We will have a separate lecture on that. So there may be internal losses in the form of hemolysis. Now, please note down that further etiologies will be determined on further tests. You just have to have basic workup, and you can determine what is the cause of anemia. But some further investigation, like colonoscopy, like gastroscopy, like upper GI endoscopy, and other tests may be needed to determine the actual cause. Stool occult blood may also be needed. In the history is a great resource at our disposal. When we talk to the patient, we get important clues to the diagnosis of anemia, and symptoms of anemia may be very subtle. Patient may complain of palpitation or early fatigue. Palpitation because of increased blood volume, and because increased cardiac output, there may be palpitation. And of course, if blood is not enough in quantity, and during exercise, during physical exertion, one may feel fatigued. Nutrition, I think one must also ask the details about what patient eats. The commonest cause of malnutrition is non-availability of food. That usually means poverty. But sometimes patient has some abnormal eating behaviors, so that may also cause deficiency. Somebody may have preferences for a specific type of food which may be deficient in certain nutrients. So I think some history about the food intake must be taken. And then chronic blood loss. This, in my opinion, is the most important. So any patient coming with anemia, you must think of chronic blood loss before you jump to any rare diagnosis. Menorrhagia, as I said, is the commonest cause, and I think you need to provide a private and a confidential environment to ask these personal questions. And many women, especially young women, they actually may not have any idea how much blood loss per cycle is normal. And I don't really think that there is actually a standard. So if some woman is having chronic blood loss in the form of excessive periods, that patient might not be actually aware of this fact that that woman has this menorrhagia. But if there is a recent change, then probably the patient would know. GI blood losses, either loss of blood, frank blood, patient may be able to identify passing blood per rectum, or it may be occult blood, which is in the form of melena, maybe dark black stool. Liver diseases, liver disease is unfortunately common in our country, and liver diseases are fairly common causes of anemia. There are multiple mechanisms where liver can cause anemia. One of them is chronic GI blood loss, but there are other mechanisms also. Worm infestation, historically a common cause of anemia, is still not rare. It is still common in our country. Then transfusions, I think you must always ask about the history of transfusions. Transfusions may be related to anemia in many ways. One thing is, if somebody is having multiple transfusions since childhood, this would probably indicate toward a hereditary cause, maybe some hemolytic disorder, maybe thalassemia. I think in history, transfusions is very important. And family history. There are some anemias, particularly thalassemia, which runs in the family. So I think family history is important. So for youngsters and graduates, postgraduate students, when you take history, I think you must address all these issues. Just from the history, you may get very, very important clues to the diagnosis. So I said in the beginning that you need to do some workup before you start medication. But if the history gives you very, very strong clue to the cause, then you may not go for the test. For example, history of chronic GI blood loss. You should then focus on the GI blood loss. And similarly, if there is menorrhagia, maybe you can start treating these patients without going into the details of the etiology. Physical examination. Pallor is the standard basic clinical sign of anemia. Pallor can be seen on the face, can be seen on the conjunctiva, can be seen on the palms, can be seen on the tongue and lips. Pallor is important, but it is very, very subjective. Pallor actually means loss of pigment. Even those people who have a dark complexion, they would also have pallor when the red pigment is reduced. So that is the routine feature. This is common to all causes of anemia. But then there's a physical abnormality called koilonychia. Koilonychia is the spoon-shaped nails. This will occur when two conditions are met. One, there is iron deficiency. So actually koilonychia occurs due to chronic iron deficiency, not due to anemia. So this would be specific to chronic iron deficiency anemia. So it has to be iron deficiency as a cause of anemia, and it has to be really chronic to have the koilonychia. But this simple inspection of nails gives you such an important information that this patient has got chronic iron deficiency. Then you of course examine the whole hematological system, and you must look for spleen, or you must look for any purpuric rashes, and you must look for lymphadenopathy. These, and also for hepatomegaly. So if any of these are present, this could actually indicate a potentially serious cause, because this could reflect a hematological disorder in the form of hemolysis, or some malignancy, some lymphoma, some leukemia, aplastic anemia. So I think based on these signs, you may build up your differential diagnosis. There is most probably something potentially serious. But these tests are actually simple signs of anemia and chronic iron deficiency. They are likely to be present in more patients. Lab investigation, lab evaluation, very important. I think some limited lab must be done in all. At least you need to have a CBC, if not more. So we'll discuss how these labs are done and how we can refine the etiology of the anemia. So routine test for anemia is CBC. CBC is short of complete blood counts. Now previously we used to have blood complete examination. Blood complete examination used to consist of HB measurement, total leukocyte count, differential counts, and then examination of peripheral smear and the ESR. But CBC is done by machine. This actually determines hematocrit, and you can also calculate hemoglobin from hematocrit, and it also determines RBC's indices. And I think shortly we will discuss what I mean by RBC indices. So I think routine CBC must be done in all patients. You can have this basic information. Then specialized tests. Many tests may be actually indicated based on your initial clinical impression and also based on the results of CBC. So this is actually what I want to emphasize. A correct interpretation of CBC and proper history and physical examination can lead to further, you can determine which tests are needed, because there are actually numerous blood tests, numerous other tests which may be directly or indirectly related to anemia. So to save patients money and also to avoid unnecessary exposure to these tests, an intelligent approach is very much needed. Basic hematological workup, CBC, peripheral smear, and ESR or CRP. ESR is still done manually. ESR is erythrocyte sedimentation rate, which is done manually, and CRP also reflects the same. Both actually represent chronic inflammatory state, and since CRP is done by a machine, world has shifted from ESR to CRP and to save human resource. So now we should be talking mostly about CRP, but ESR is still valid test, and if ESR is high, that would indicate something chronic, some chronic infection, although anemia itself would lead to increased ESR. Peripheral smear, I think although CBC is done by machine, we get very correct measurements in indices, but the kind of information we get from peripheral smear is very, very important, though it may not be needed in all, but in some difficult cases, I think peripheral smear, which is actually staining in the smear and then examining it manually by a human, by hematologist, this can give us very, very important information, especially when we're talking about some unusual causes of anemia. So these three would constitute what I call basic hematological workup, but in some cases you might need actually many more tests. Now we will be discussing basic of CBC, and the title I gave to this part is Deciphering the Hidden Secrets of CBC. It's small test, but it can give you very useful information. Now, for comparison, this is the report of CBC. Not very impressive, very small, computer generated slip, hardly gorgeous. And it is as unimpressive as the small invoice you receive when you eat from a restaurant. So look at this one, not very impressive, but it has got a lot of hidden information. Now, before we discuss the various causes, various abnormalities, first let's have some introduction. It is a computer generated slip by an auto analyzer. This is the machine called auto analyzer, and the first one which became famous was Coulter. I think Coulter is a brand. It is perhaps still available, but then many other came in. They have various features, but it calculates automatically the HB and hematocrit, and it counts the RBCs, and it measures all the indices. Give counts, indices, and morphologies, and interpreted along with history. Gives important clues to various hematological disorders. And terminology, RBC count. RBC count is in millions per liter, and HB is in grams per deciliter, and hematocrit is the same as packed cell volume, the percentage of actually packed RBCs when you centrifuge it. These are measured directly by the auto analyzers, but then there are several values which are calculated from these indices. The built-in computer calculate various indices. These are mean corpuscular volume. Now, it's self-explanatory. Corpuscular is actually RBC. So mean corpuscular volume, the average volume of an individual RBC would be referred to as MCV. So it will tell us if the RBC is of normal size or bigger than normal or smaller than normal. Then we have mean corpuscular hemoglobin. That is the average amount or the mean amount of hemoglobin present in one RBCs. And it would be referred to as normochromic if it is normal, or hypochromic, or there's no hyperchromic actually. In this category, in MCV, RBC's volume may be referred to as normocytic when it is normal size, and microcytic when it is smaller than normal, and macrocytic when it is bigger than normal. Here it is hypochromic when the average amount of HB in RBC is reduced, or normochromic when it is normal. There is no hyperchromic actually. Then mean corpuscular hemoglobin concentration. This is another term, and I think I will very shortly explain what this means, but it is actually the concentration of hemoglobin within one RBC. This index is important. Then red cell distribution width, RDW. This is also an important parameter of CBC, and I will also explain what it means. Now these values are actually derived. Okay, so if the measurement of any of these is incorrect, this would of course lead to incorrect calculation of these also. Machine would measure these three things, and then applying various inbuilt formulae, they will calculate these parameters. Now, this is the graphic representation of various terminology. This would be called a normocyte. Just imagine this is the cell of, this is the normal size of an RBC, which is I think 7 micron. So this is the normocyte. If you have a cell which is smaller than this, that would be referred to as microcyte. And if there is a cell which is bigger than that, that would be called macrocyte. So I think we need to familiarize ourselves with these terminology. Normocytic, microcytic, and macrocytic would be referring to the size of the mean cells. Then this is normochromic. Just see how much pigment, how much color this cell has, and if it is pale, this is much paler than this one, you can see, and this would be then referred to as hypochromic. Chrome is color. So if this color is normal and this is hypochromic, that means it is pale, it has got less pigment. And then we have another cell which is also hypochromic. Now how to differentiate between these two? These two cells are hypochromic, although the average amount of hemoglobin in this is much more than this one, and it may be actually equivalent to this. But how to differentiate? If you just go by mean corpuscular hemoglobin, these two cells may have the same amount. I mean, of course, not necessarily so, but this is much bigger, though it has got less concentrated hemoglobin. So average amount of MCH may be same in both. But how to differentiate these two cells is by mean corpuscular hemoglobin concentration. If this is normal, this mean corpuscular hemoglobin concentration is reduced. So this is how this term MCHC is useful. Otherwise MCH would be sufficient, but to differentiate between these two cells, if you go by amount of hemoglobin, both will show the same. But if you go by mean corpuscular hemoglobin concentration, these two cells will be differentiated and will give us different etiologies. Now, this is another thing which I would like to explain. RDW. RDW is actually red cell distribution width. Now, please note down, this is not the width of the RBC itself. This is the width of RBC distribution, and it would also refer to as, if RDW is increased, it would indicate that the variability in cell size is increased and there is a kind of anisocytosis. Normally cells are 7 micron, maybe slightly bigger, slightly smaller, but if the variation is much more, then RDW will be increased. I'll try to show you in the form of a picture. Suppose this is the normal distribution. Most of the cells in our circulation are of this size. Some are smaller, some are bigger, and it will produce a curve like this. Okay, and then there's another picture. So we have main size is the same, but we have many bigger cells of variable sizes and many smaller cells of variable sizes. In this, the curve will be much broader. So this breadth of the curve is referred to as RDW. It does not indicate microcytosis or macrocytosis or normocytosis. This would actually indicate that what is the variability of the RBCs. Now this can also provide an extremely important clue to the diagnosis. For example, in iron deficiency anemia and thalassemia, we have a hypochromic picture in both conditions, microcytic picture. But in thalassemia, RDW will be much narrower because all RBCs are smaller uniformly. Whereas in iron deficiency state, depending upon when during the history a particular RBC was made and depending upon the degree of iron deficiency at that time, the cell may vary in size. So in iron deficiency anemia, RDW will be increased. So very simple parameter on the peripheral smear can differentiate between a common condition like iron deficiency and a relatively less common condition, thalassemia. So this is the value of RDW. This is perhaps the last slide, and we are going to end here after this one, but we will discuss about the morphological classification in the next lecture. So we will first have CBC, and in CBC we will look for MCV, mean corpuscular volume, MCH, mean corpuscular hemoglobin, and MCHC, mean corpuscular hemoglobin concentration. And based on these parameters, patient may be classified to have hypochromic microcytic anemia, which can be due to iron deficiency, the commonest cause, although iron deficiency itself may be due to several other causes, but at least to this extent we can make a diagnosis that this patient has got iron deficiency. Another possibility is hypochromic microcytic anemia is thalassemia. Thalassemia, of course, are much less common as compared to iron deficiency, but they're not rare at all, especially in our part of the world. We live in that belt where thalassemias are common. Thalassemia, there is a separate lecture on thalassemias, but just very, very briefly, it is common, and thalassemia major would be diagnosed early in the childhood. So in the differential diagnosis of anemia in adults, we will be mostly dealing with the thalassemia minor or thalassemia trait, but that is not rare at all. Then if the picture is macrocytic, then again there are two possibilities. It could be due to vitamin B12 deficiency. Vitamin B12 deficiency itself can be due to several causes, or it may be due to folic acid deficiency. Of course, there are other causes also, but I'm not going to go into those details in this lecture at least. So these two possibilities should be raised when there is a macrocytic picture. And then there is normochromic normocytic anemia, and the two important conditions are aplastic anemia. In aplastic anemia, bone marrow is not working properly. Bone marrow tissue may be reduced in volume, and there is fewer RBCs that are produced, but those RBCs which are produced and are released into circulation, they have normal morphology. So although there will be some other important clues in the peripheral smear, but as far as the CBC is concerned, RBCs will have normal morphology. So that will be normochromic normocytic anemia, aplastic anemia, and then hemolytic anemia. Hemolytic anemias may also have macrocytic picture depending upon when you drop sample, but it may actually fall within the normochromic normocytic range. So this is actually very brief introduction, and actually we are going to discuss this concept in the next lecture. Initially that was part of this lecture, but I think to manage time better, so I have divided into two lectures. Please join the next lecture also to have better understanding. So thank you very much. This is Professor Azizur Rahman from Medistan. I hope I was able to give you some introduction to the approach to anemia. History is very important. Physical examination also provides important clues. I told you that the palpable lymph nodes, purpura, splenomegaly, hepatomegaly will indicate something potentially serious. But most other patients, just history and basic CBC can give you very important clue. And I also emphasize that best time to investigate and to a case of anemia is before starting medication, before giving blood transfusion. So I think I'd like to see you in my next lecture. Please, there is going to be a series of lectures, about 8 or 9 of them on anemia. Please attend all those lectures to have better understanding. Anemia is a common condition, and intelligent approach is needed to come up with the correct diagnosis and the correct treatment plan. Thank you very much. I'll see you in my next video. Thank you.